principle. So let me stick on to the infection part. Single stage versus two stage, always there is and nowadays more and more international surgeons coming to India for meetings, they advocate a single stage. Let us see what the literature says. We know that TKR fails because of infection, second largest cause. But here we deal with these kind of gross infections and the management becomes very, very difficult. But one thing we have to be very careful. These are the four things definitely we have to take into consideration: the host comorbidities, condition of the soft tissue, cultured organism, and the technique. Whatever might be, whether it is a single stage, two stage, these four must be taken into consideration. And in our part of the world, we deal with these kind of problems. And when these problems are there, then based on this, based on the patient, we have to take a call whether it is single stage or two stage. We cannot generalize and say always this is the best. One stage exchange in TKR in a chronic PGI. Again, if you look at the literature, this is very recently published in 2019. It says that it can be a big advantage in regards to the functional outcome. Single stage, decreased morbidity, mortality. Yes, morbidity is low, but mortality is questionable. Increased in the quality of lifestyle is good. But again, they have mentioned that local non-immunocompromised host and minimal bone loss, microbiology is important, but at the end, the two stage is better than the one stage revision. Let us take this example: 49-year-old female, TKR done, DIAR done, but no growth. And the patient came back 10 months later with again a florid infection like that. So are we justifiable? Can we do a single stage revision? Yes, some surgeons who are skilled enough, they will do a single stage revision, particularly endoclinic does this routinely, single stage revision. But I was comfortable in doing a two stage in this case, and the outcome is good. So when it comes to PGI, either we deal with two things. One is culture positive and culture negative. Culture positive, it becomes little straightforward by giving the appropriate antibiotics. But if it is culture negative, then it becomes a difficult challenge to diagnose the organism. And again, an atypical organism both puts together a lot of challenge. Culture negative, again diagnosis is challenge, and we need to have high clinical suspicion because organism is not isolated. This slide you would have seen from morning, routinely used, definitely very good protocol which gives us to diagnose the infection. So acute infection, we see a lot of cases like this, and in that scenario you have to do a proper aspiration without antibiotics, and then DIAR is the treatment of choice, no doubt about it. This classification, this criteria helps us to deal whether to do a DIAR or to do a two stage procedure. But when it comes to single stage, a lot of other criteria you have to follow which are very, very important. So when you see these kind of cases, DIAR is strictly not advisable. Again, in chronic infection, you have to see the patient as a whole. But if you look at very closely, there are signs of loosening, so DIAR strictly not a case. So can you do a single stage? Again, you have to see what the patient has got additionally as a host comorbidity factors. So in a patient in India, we published this in Journal of Arthroplasty. This is a questionnaire done with all the arthroplasty surgeons, and we got these many comorbidities which we deal in India, which are all in high numbers. So is single stage revision a safe bet in these numbers? Again, the surgeon has to decide. Ridian Mahajan is a full-time single stage revision surgeon, and they have published what is that, why organism is not isolated. Many things: antibiotics, low virulent organism, and then again sampling techniques are all a big problem. When they have this problem, imagine in India how good is the technique of diagnosing. So lack of diagnostic facilities also puts a single stage at the back stage. So in this study, they have said that none of these reasons were sufficient to prohibit the use of single stage revision. Debridement was the key. But remember, this is in UK, and when they say a single stage, this is how it is. Look at how radical they are, and the majority of the time single stage revisions in endoclinic also, it lands up in a hinged processes. So are we justifiable in doing such a radical debridement? That is the big question. So are we ready to do a radical procedure? So at the end, Radian Marker Jones has concluded that single stage revision is effective, strict debridement, culture negative also is not a contraindication, but we have to be very, very careful. But two-stage revision, yes, it has got its own challenge, bone loss. Dr. Rajesh Malhotra has very elaborately explained how to address this bone loss. Why that bone loss happens? Prolonged cement spacer in a two-stage. So you have to be very careful not to allow the cement spacer for long period of time. Classify it properly, follow the principles which Anil has mentioned already. These principles, if it is followed, then bone loss management becomes easy. Variable options are available to manage the bone loss in a two-stage procedure. So you have to make sure it is a combination of both soft tissue and the implants. It is not only the implants which can manage the bone loss, it has to be the combination. So again, two-stage revision. See this patient underwent a two-stage revision. A simple semi-constrained implant is enough because there is no bone loss. So no sleeve, no hinge, no tumor processes. Again, one more example of two-stage procedure. Once you do that, in this case, just because there was a distal femoral bone loss, I had used only the augments and one stem in the tibial side, and again only a semi-constrained. Sleeves and cones, yes, it was covered in the previous talk. So make sure if there is no bone loss, a two-stage revision also is not a big challenge. You can use the simple implants as much as possible and then get away with that. So sleeves and cones plays a very, very important role in two-stage procedure. This case has had a bilateral infection, and in spite of that bilateral cement spacer like that, two-stage revision, both sides, patient is doing well, 5 years follow-up. So if you look at the literature, both gives good results, one single stage and two stage, but definitely two-stage approach continues to be the most commonly performed procedure, and it is a safe bet. But sometimes you have to do a two-stage procedure but end up doing a hinge processes if the bone loss is very, very severe, but a rotating hinge process nowadays give good results. Sometimes you deal with atypical organisms and TB, and these kind of cases definitely better to do a two-stage procedure rather than taking a chance of doing a single stage. This case metaphyseal bone loss and ended up doing with a tumor processes. Chronic PGI, sometimes it will require multiple procedures but end up with a fusion. So in these cases, single stage definitely doesn't help. So what is that best bet? A systematic approach and a multidisciplinary approach is very, very important. Involve the other specialists also. To conclude, antibiotics, free period, culture the correct samples, malnutrition has to be taken into consideration, but polymicrobials nowadays and comorbidities decide whether it is single stage or two stage. When it is polymicrobial and comorbidity is very high, better to do a two-stage procedure, which is the gold standard now. Thank you.